What I wanted to do is to give you some overview of the e-health situation in Norway, more as an initiation for discussions. It's of course not deep, it's rather wider than deeper. And I'll try to say a little bit also about our own research in this, but it's not mainly about our own research. Ole will do more of that later. Another disclaimer, it's not an official presentation, even though I talk about the Norwegian policies and the official initiatives. I'm offering you my unofficial analysis of this, even though I did take some of the official figures, but I give you the sources for that. I wanted first to mention to you just an overview of what we call national e-health solutions that are existing or in the process of being introduced in Norway. And spend most of the time on the EPR system, the patient record systems, both in the hospitals and in the municipal care. So that was my plan. We have some national systems covering the whole country. And I want to say a bit more about two initiatives that we follow with research of these. And then there are two major EPR projects that I've been communicating with Robin about that you were interested to hear more about. Yes. First, some key facts. We are a small country. The population is 5.3 million, so comparable to Scotland, I would think, but we have more GPs than you have, 4,600. This is, of course, a public health service, dominantly public, as the other Scandinavian countries. I think we are quite high on the expenditure compared to other European countries, and it has to do with how you count the components of social service into these numbers. You see on the map different color codes, and that is the regions. The specialist health service in Norway is the responsibility of 4 regions. North, Central Norway, West, and then Southeast, which used to be 2 regions, but they have been merged. We have a division between specialist healthcare and primary healthcare. Different governing systems for those 2 levels. The municipalities, we have now 422 municipalities, are responsible for primary care and social care, and the GPs, the institutions, and the home services are under the municipal umbrella. The specialist care is governed by these 4 health regions. And you see, if you can see the graphics, the north is the smallest, with 9% of the population. The central Norway has 14%, the west 21%, and this southeast, the largest one, is 56% of the population. So that's the region we have worked most closely with in our research, so Ole will say more about that later. Yeah. 90,000 employees in our hospitals. We've had, of course, a shift from inpatients to outpatient services over the years, like most countries. Yeah. Yeah, I don't know if, I think I'll skip this. In terms of digitalization, Norway was one of the pioneers to introduce electronic patient record systems. At least we claim to be. I think back in 1983, there was the first pilot of a live EPR across a whole hospital department. So not just a small pilot, a test, but in real use. And these curves show the blue, the first to rise was the GP offices. They were digitalized throughout the 90s, basically. And by early 2000, almost all of them had acquired electronic patient record systems. This middle curve, green, I'm not sure how they count, because in 2008, that's when the last of the public hospitals acquired an EPR system. So this must be another usage matrix. But all of them have and use electronic patient record systems. And the last curve here is the municipal care services that were the latest to install EPR systems. But in general, we have a good coverage of digital core systems in the organizations, and we have not so good integration between them. So that's probably a common story in many places. The governance structure, since we have this division in primary and specialist healthcare, is somehow complicated. The municipalities have constitutional autonomy to do the decisions they want to do, and they are under one ministry. The specialist health services are under another ministry, Ministry of Health and Care Services, and some executive organs to implement, which do not have a direct line of command to these regional health authorities. The ministry has, of course, but the tradition has not been to give any detailed instructions on ICT policy. It's been very, very generic. The national solutions that I will talk about are developed by these entities for the whole sector. And then the specialist EPR solutions are developed by these regional health authorities, each by themselves. And this is called the Directorate of Health, the Directorate of Ehealth, and the Norwegian Health Network. And this directorate is quite new. It starts its third year of life, and the ambition was to take more national ownership over this domain. And they've installed this governance model, which they have tried now for 2 years, and this is the third. They've established a national advisory board, recruiting key stakeholders from all the relevant institutions, like Institute for Public Health, the Association of Municipalities, Medical Doctors Associations, all the key stakeholders, in order to create a consensus forum for Ehealth strategy. And they've installed a body that is a strategic advisor on these national projects, and also a more professional advisor, both medical and technical competence advice on these Ehealth strategy. So this governance regime have worked for a couple of years, and I think it's getting more their hands on the actual implementation of Ehealth. But their domain is still the national solutions, not the regional. So a little bit about these. We have a shared broadband infrastructure since 2009, this health network. And even before that, they developed a code of conduct for security, for information security, that has also served as a joint resource. So all hospitals, all GPs, all municipalities are connected to the same broadband network. That was one of the first successful national services. For many, many years, they worked on establishing electronic messaging between actors. It's been a slow process, but there are no standard messages. Referrals, discharge letters, laboratory response, all of these ISO 10 type of standards. The e-prescription also had a long story, but is now rolled out as a national service. For GPs, hospitals, out-of-hours service, but not for the municipal healthcare yet. That is coming. We have, for a few years, 5 years, had a summary care record for critical information meant for the acute services. It's been It's been rolled out region by region. So last year, also our region, Southeast, we could get a summary care record. It's not a lot used. This is the GPs of the individual patient that's responsible to populate this with information. And not so many of them do that work. We have a citizen portal that also gives general information about rights, about hospitals and their services, about waiting times, quality indicators, all of that generic information, but also login services with personalized information. My prescriptions, my vaccines. I can look at a summary care record. And for 2 of the regions, the North and the West, you can look into your record system, but not for our region. On health data and this ambition of one health record, I'd say more later. They are not yet there. So this is just a screenshot for the login services on the citizen portal. You can see your medications, the active prescriptions. You can change your GP. GP is we have the family GP model with one GP that we are allocated to. And we can change here. The core record, some of these other full records, all our appointments, messages. If you have this appointment service, there is also messages and referrals. So a lot of more on the administrative type of services, information services. Here I put a slide of a book where also Robin and this gang here has a chapter on from the UK. We write the history of this portal in one of the chapters in this book. It's an open access book, so freely available. In terms of usage of these services, that portal, the citizen portal, is quite a lot used. We are a population of 5.3, and there were 18.7 million visits to the site, and 7 of them were login visits, so real people wanting to use these services. It's higher compared to many other of these portal services in Europe. It's a quite high usage. A lot of usage of electronic prescriptions, and also the lookup of your vaccinations. So the usage is growing, and it's being monitored by the government. Just to mention another of the chapters in that book by Ola and a colleague who studied this e-prescription. I said it was a long story from the start, and here you see a timeline starting in 2001. So that was a long and cumbersome way to the goal. Not the least because of the architecture they chose required that a lot of actors be mobilized and coordinated for this to be realized. And then it didn't go as planned, of course. So that in itself is a story worth to delve into. So we did research on some of these national infrastructures. And currently we do research on what we call, it's a Scandinavian term, welfare technologies. We have a national rollout of GPS systems and alarms, digital keys and cameras either in nursing institutions or in homes equipped for patients to stay at home longer, elderly patients. So these kind of technologies and medication dispensers that gives an alarm when somebody does not take the medicine or gives a signal when they take the medicine is also rolled out. And then the component which we follow is not those, but when you have medical data being transferred. So remote patient care. We followed a company that runs a service where the patient at home has a tablet and then connected measurement devices, pulse oximeter and BP measurement and weights and spirometer if this is COPD. So COPD is one of the diagnoses, diabetes and cardiovascular diseases. So they registered at a regular interval, maybe once a day. This data, it goes through the tablet to a cloud repository, and there is also a questionnaire, so not just the numerical data, but also they answer questions about how they feel today and different things. And then there are what is called response centers in the municipal care where the nurses monitor the data and the trends and the questionnaires. So we've followed different implementations of this service through the first round of trial implementations. One with the focus on work practices. How does nursing work change? How does nursing work look like in the response centers? And we have a couple of publications on how the nurses work with patients. It's not just a passive monitoring activity and acting when there is an alarm. There is much more of a, a mobilization and a teaching activity going on of the patients. They learn to interpret the data themselves. They learn to connect these data to the disease and the symptoms. They learn to manage their lives differently. So that kind of thing we've been interested in. And also we're interested in the technical infrastructure that the government tried to put in place to facilitate this. And the architecture of this technical platform, and how does it connect to other infrastructures. They started with a reference architecture, sketching this domain. They moved on to thinking about a platform, and today they talk about a hub. So these ideas of what this should be has changed over time, and the main factor for that has been the need to realize what should the government do into a market, how to stimulate the market and maintain governmental control at the same time, how to balance with all the vendors. Because the EPR vendors, I didn't say something about that. This is a separate system. In some instances, they copy manually to the EPR. In others, the EPR have functionality. So the EPR vendors would like to take more of the market. But these systems providers would also like to take more of the market. So when the government designs an architecture, they interfere in this dynamic. So that has been a process we have followed. And what kind of services gets configured here? Two different installations with the same product has been very different. In Oslo, this was installed in the municipal care homes, and the nurse became the core linchpin, the coordinator for these services. The nurse would communicate with the patient, would involve the GP if necessary, or call the hospital if necessary. In another city, the patient himself or herself was the responsible. And this response center nurse would only communicate with the patient and saying, for instance, I think you should call your GP now. This is not looking good. I think you should call. And so what role does the patient get in these configurations? Is it empowering or is it a traditional role? It's one of our interests. And as I said, what architecture becomes underlying this? I think it's a significant, we are building a significant infrastructure for the future societies when we build these things. So it's interesting to follow. I can mention briefly also that there is an ongoing initiative to use all the registries. We have a lot of good registries going many decades back in Norway. Central health registries, national medical quality registries, and also not so wide-ranging, but many hundreds medical quality registries, many hundred biobanks. So all of these resources, they try to make it more easily available for research. It's also one of the big programs currently. And the health data platform has also, I think maybe learning from the care.data history here, a strong emphasis on the citizens to build, accept, and to give consent, the consent management part, and also the ability to log in and see who has used my data for what purpose. So there is, all these registries are going to be made available for analytics services. Some of the data will be open, some of the data will be restricted, and you apply and you get access to data like today, just more easy process. And some data they will not deliver to researchers. They will let in these analytic engines and do the analysis inside the securer area. But this is a project which explicit innovation agendas, wanting to also generate value from health data. So it's just so you know about it. It's ongoing. So there was this brief view of the national solutions. And please ask if there is things I should go into more. And if not, I'll say something about the EPR systems.
I had one question.
Yeah.
So Norway is a beverage system, yeah?
It's a
beverage style system?
I think that's right. I'm not an expert on this.
What's the equivalent of, we have this thing, the National Institute for Clinical Excellence, which kind of approves or disapproves treatments. Yeah? Because in a beverage system, you have to think very seriously about how the resource is distributed.
Yeah.
And I didn't see something like that in what you described.
We have, in the Directorate of Health, there is, I don't know the technical terms for it, but there is to some degree, on medication, there is a centralized decision if this is being reimbursed or not, use of this medication. On procedure, clinical procedures, I think there is some more anarchy. There is still a lot of professional autonomy in which procedures you follow. And this the wish to implement more standardization.
But still there's a kind of budgetary decision at
there
the
is.
level of how much of GDP, say,
yeah,
is going to be funded.
Right. We have this combination of block grants and activity-based costing, the diagnosis-related group things. So there is a body that of course, sets the sum for each diagnosis and each treatment. Yes. Yeah, it's part of an answer, at least. We've got a quite ambitious strategy based on a white paper from 2012. It says, one citizen, one record. That's the ambition. We shouldn't have this fragmented landscape. 3 goals. Healthcare personnel should have easy and secure access to health data. The citizen should have access to more online health services. And the third, data should be available for quality improvement, health surveillance, governance, and research. So that health data platform I talked about, that program is targeting this goal. And the citizen part is mainly targeted by the portal, the work on the portal. For the health personnel access to data, there are 3 initiatives. And one of them is the Central Norway initiative. And this is my, what I mean with one record is primarily the EPR and the patient administrative system part. So PAS or ADT, I don't know what people call it. So the core thing should be one system, and then there should be interoperability with more components around it. And the situation with respect to EPR, if any of you have read Ole's previous work, we've written the story about how the regions developed a Norwegian EPR in the 80s and 90s. That product was used in all regions, and now it's only used here. The 3 other regions have implemented another Norwegian EPR system called DIPS. It came from a small hospital in the north, and it's grown and been adopted widely. The north have, I think, they have 6 locations. I think they actually have 8 locations for their hospitals, but they've made one consolidated database for the EPR system. The west have done the same thing, but this region has not managed to do that. So they still have 9 installations of the EPR system. And in mid-Norway, they are now in a tender process to replace the existing EPR with one of these suite applications. They've had a tender process with first 11 bidders, and they're now down to 1 because others, they selected 3 and then 2 of them disappeared. So they have only Epic left, and we expect them to sign the contract now in January. And they want to deploy it both for the specialist and the primary care. So that's the new thing.
Quick question, if I can.
Yeah.
In terms of the region which has 50% of the population, was that the south?
That's this one, yes, southeast, which is the most fragmented and messy situation, also with system landscape. This has the DIPS vendor. So these 3 regions using DIPS have also a joint process trying to consolidate their strategy towards this vendor. I'll say a bit more about that. So making a map of the regions, specialist and primary, this central Norway has the ambition, this big project, to cover both primary and secondary. There are the DIPS-based existing system here, which are now being aligned. And the third big thing is a very early phase process to create one national solution for the primary EPR systems. And this is my unofficial analysis. The region, this was not the model that the Directorate wished to implement from this white paper. But they were too early. That was before the Directorate really had this governance structure in place. So they started the tender process. And now we have to live with this bit mixed situation. Formally, they are a national trial project for this model of EPR deployment, this joint project. Yes, so it is both the regional health authority and the biggest municipality are project owners. And they have committed to deploy this when they're ready. So both hospitals, GPs, nursing homes, home care services. In the region, it has 720 inhabitants and around 40,000 healthcare professionals. And 270 million euro budget for this. Yes. We are now here where we expect them to sign a contract. The next couple of years will be adaptation and implementation of the product, with implementing in the municipality in 2021. That's the plan for this project. And they've had a lot of focus on the user requirement process, and they worked a lot with areas of particular, of course, basic capabilities, but also on, they want closed-loop medication, they want more decision support, they want more structuring of clinical processes, a lot of ambitious aims for this. You will find also English documents on their webpage. The tender documents, they promise, are there. And I said we had a message exchange, sending a message from one EPR system to another. That's the old model. They want to implement an information sharing paradigm instead of this. They want to standardize a lot. They want to have structured data. And they want, of course, an innovative platform. There are probably many skeptics waiting to see what happens around this. We can discuss that more. These other 3 regions have that consolidation project. And they try to approach the vendors in a coordinated way, which is sensible. They are also waiting for a new EPR product that they've waited for some years. It's now in the first implementation in a small hospital. That is the product which uses this OpenEHR archetypes that we also talked about. So it has structured information, much more standardized patient trajectory, and process support and decision support. So that is one of the key elements of the strategy of the other regions to implement this. They expect to do it this year. And should I say something about these archetype things, or maybe you know it? This is a 2-level modeling approach, where you have a minimal reference model with the kind of core components of medical information, and then you combine this into archetypes. And the archetype should be reusable and should be used by, the ambition is nationally. So these are more formal definitions. And if you separate the technical concerns from the more clinical or work-related concerns, the idea is you can have a more well-designed EPR. You don't hard-code everything of the things that are changing all the time or changing from one to another location, but you kind of separate these. So it has these 2 levels, and it's not a standard in that it lists which archetype should be there or which concepts should be there. It's more a recipe for modeling. So you need to set up a process of defining this. And it's called, the international community has this clinical knowledge managers where you propose an archetype, you get clinicians to review it and say yes or no. So there is a process. And recruiting these have of course been challenging. Which clinician have time to really invest into these processes? And you can bind them to terminologies, but that's a huge task of course. What is interesting is that this approach, having these archetypes, allows quite a lot of local flexibility when you have the software product. You don't need to do much programming to make new screens, new documents, new reports. So it does allow a lot of flexibility, and that's the main rationale for doing this. So in Norway, this EPR vendor committed in 2011 and wanted to build this as the base for their new record. And there was a national governance unit established in 2012, but with very slow progress. So this vendor started to do their own development. I think after a year, there was just one archetype being defined, and you expect to need around 1,000. And this was not even developed, it was just translated from the international vocabulary. So they couldn't wait. So they did in-house development, and then that was, of course, creating tensions. And what they have done is to take an international product into their new version, which they now rolls out. Before Christmas in a psychiatric unit, and now in March for the other clinics. It's a small hospital in Oslo, which we follow the implementation of. Okay, I'm probably going over time, but very quickly, this ambition to build one municipal system. It's very early phase, as I said. It comes from this strategy. And the landscape now is that we have a lot of small vendors for the GPs, for the nursing services, for the health stations and school health services, and physiotherapy and others. And they are, small. They don't follow all the requirements that the government want to set for the quality. And there has been this process of saying we need one shared record that supports collaboration between health personnel. It should support collaboration with the citizens, with the welfare services, school system, other public services, other health services, and also beyond the health service, also the home care, other municipal services. And they've been in the process of deciding on the concept, and they said, yes, we want one national shared EPR solution, where each municipality has its area, but it's the same solution. And that's, as I said very early, we expect next year, or they'll try to schedule a formal decision next year. And then, these are the very heavy quality assurance processes, and then it takes years, as you see. So I don't know, frankly, what happens with this, if the sector is willing to wait for this, or if there is other things coming up, vendors coming in with new services in the meantime. Yes, that was a very kind of high-level, broad overview.
We've heard Anna's talk, so can we thank Margunn for that very